Morning everyone. Hopefully all good. Everything seemed to freeze for a second then. I was getting a bit worried, but it looks like everything is okay. If you want to drop me a message, perfect. I was just going to say, just to make sure everything's working. Thank you, Becky. Good morning. Good to see you there. Welcome. So we've got a good morning. There's an unexpected guest. Well, good to see you, mate. Looking forward to you coming back home. Yeah, so that's my son. If anybody wants to know, well, obviously with it's a YouTube account, so you can follow him on YouTube. Welcome back Monday. So we've got back on a Monday, which is good. We did Tuesday, we did Wednesday last week, which was a bit weird. Always kind of throws my week out when we do a different day. So yeah, ready to go this week and start the week as we mean to go on. We did the bones and joints of the shoulder. We were looking at the structure of the shoulder girdle and the shoulder joint last week. And this week we're going to finish that off, and then we're going to add on some of the layers for the connective tissue. So having a look at something called the labrum and some of the ligaments as well that keep the shoulder intact, basically. We should cover all of that today, and then once that's done, then we will we'll move on to the muscles. So we'll start to add on the layers of muscles. So we'll look at the rotator cuff and then all of the muscles of the shoulder girdle. And once we've done that, we'll then have a look at the nerve supply and blood supply for the shoulder region, which then goes down into the arm. So if you've not done this before, because I know we've got a few new people watching, then we start off with the bones, and then we basically build on that and build out until we've done everything, basically. Once we've done that, we'll then move on to the elbow, and then we'll connect the structures of the elbow back into the shoulder. So then you've got the pathway all the way through. Well, we've got quite a few in. Morning, Tris. Morning, Mo. Hello. Caroline, you're going to get sick and tired of me over the next couple of days. I saw Caroline yesterday as well. So yeah, you've got my voice. And I saw Steph very briefly yesterday as well. So good to see you. Did you go to one of the old ones? Yeah. So I'm trying to use the same format for each section of the body, and then change that so it's easier to see what bit's what. So apologies if it was confusing. Right, let's get going. So this is where we left last time. Just get rid of that. Just wait. Okay, so this is where we left last time. We were looking at the collarbone and the shape of the collarbone and some of the bony projections from the collarbone, because we probably don't notice them actually until they get pointed out. So yeah, we were looking at this. So it's a double curved long bone. There's so obviously two curves in it, and we were talking about the reason for this, and it's most injuries to the clavicle are these. They're fouche injuries. So that is a fall onto an outstretched hand. So if you slip, this time of year's classic example with the icy weather, and you slip over, put your hand out to stop you, And if your elbow is locked, then the forces travel through your lower part of your arm into the upper part of your arm, into the humerus, and then that then gets transferred into the collarbone. And it's usually the collarbone that then fractures. And there's a good reason why it would, because if it was just a solid straight bone that attaches onto your sternum here, it could potentially go into your throat. Okay, so if you imagine that all these bones are staying nice and strong, but then it's the collarbone that fractures to protect your neck. So the shape of it and the structure of the clavicle means that it's more likely to fracture in those kind of circumstances. The sternal end, so the bit near the sternum in the breastbone of the body, is enlarged and triangular kind of shaped, but where it joins onto the sternum has a unique shape, and the movements that you can get from there are really unique as well. The acromial end, as we saw last week, is flat, so that's the end towards the outside part of the body, just here, and that's really it's continuous with the acromion. So it kind of goes along. There's a little bit of a dip that you can feel, and then the acromion attaches into it, and we'll have a look at that on the videos in a second. But that's nice and flat there. So it's hard sometimes to palpate or feel the joint between the acromion, and again, if you're not sure what these terms are, we covered them last week. So the acromion and the end of the clavicle. So because it does feel continuous, but there is a joint in there, and it's a synovial joint as well. So it's got a capsule around it and synovial fluid. It does move definitely, but this one, so the sternal one, that one you can feel moving really easily, and again we'll have a look at that in a bit more detail in a second. It varies in shape more than any other long bones, thicker and more curved in manual workers, so it will adapt. The shape of the collarbone will adapt depending on the stresses put upon it in life, and that's true of all areas of the body, but in particular the clavicle. So you might look at someone's clavicle and think, oh, that's a bit weird, that one's a bit thicker, or that one's a bit longer, or whatever, but it's entirely normal. And we looked at some of the anomalies last week. There are different classifications of clavicle, and within those classifications there are extremes. So you've got larger shapes, smaller shapes, and then the average shape for those classifications. So there's lots of different variability in the clavicle, in the collarbone. It's classified as a long bone, but there's no medullary cavity, and this is the key point of why it fractures. It's all spongy bone, so it's not solid, and again for a very good reason, because if you're falling and the forces are transferred up into the collarbone will fracture before it gets to your neck. Okay, so it's a good useful design. So this is the shape of it. So this is the sternal end here. You can see that double curve. So this is a superior view, so a top-down view, this one here, and then this one's a inferior view, so where it's been flipped. So the acromial end, as you can see here, is flat. Okay, so it's nice and flat across, and then that attaches onto the acromion. And the sternal end is a bit more bulbous, and again that's the bit you can feel here. So if you do it on yourself, if you've not done this before, you can have a feel down the center of your neck where your throat is, down into the sternum, just there, so you can feel that bony lump. Move one side or the other, whichever one you're going to have a feel of, and then whichever one you're feeling, so say it's your right side, so left side as you look at me, and then move your left arm, and you'll be able to feel the movement in that joint at that point. And that point there is the only bony attachment of your whole arm. Okay, so there's no other joint that attaches your arm to your body. It's just that bit there. So that bit being able to move is really important. So if it's a bit stiff, a bit restricted, then that can affect your all of your shoulder movements. Okay, so that's really an important joint. We do have, and we talked about this last week, the scapulothoracic joint, but it's not really a joint because it's not bony. It's where the muscles of the shoulder blade attach onto the other structures of the thorax. So it's not a true joint. It doesn't have a synovial capsule, synovial fluid, all that kind of stuff. It's literally a muscle joint. Okay, so the scapulothoracic joint is not a true joint. It's a muscle one. So yeah, this is the point that attaches onto the body. And then from the inferior side, so looking at underneath, so if it, like looking up underneath the collarbone, the sternal end looks pretty much the same. We've got this area here called the subclavian groove, and that relates to a muscle that we're going to talk about when we get to the muscles section, so we'll add that in later. And then these we're going to talk about today. So we've got the trapezoid line or trapezoid line, however you want to pronounce it, and then the conoid tubercle just there. And these are ligamentous attachments underneath the collarbone to keep your collarbone in place. All right, and we're going to expand on those today and have a look at those. So this is what happens when it gets injured. You've got a what we call a sprung AC joint. So there's your collarbone just there. The acromion is around about here, and you can see that gap there. That's not supposed to be there. Okay, so if you notice someone coming in and they've got this gap, then it will look, they will have probably, unless it's just the way they've always been, they will have separated their acromioclavicular joint. It's a definitely visible deformity, usually noticeable immediately, and very common in rugby, football, martial arts, that kind of thing. Any kind of contact sport or where there's a risk of falling. So if you do skateboarding or something like that as a kid, then you're likely to injure that area as well. So yeah, that's the joint between the acromion and the clavicle. So the AC joint just there, and that's when it gets injured. Right, let's have a look at the clavicle a second. On this video just here. So this is the clavicle. These videos are all from Ackland Anatomy, ACLAND, brilliant resource for learning anatomy. I've just added some bits to what they already do. So this is the sternal end. This is the image that we've just seen in the PowerPoint. There's the sternal end, there's the acromial end, and we'll go through that. So you can see that kind of S-shape curve. There's the end of the bone just there. So that bit attaches obviously onto the sternum, and then that bit attaches onto the acromion, which is part of the scapula. We looked at that last week. And then if we flip it, then we can start to see these bumps. Okay, if I just pause that there. So we've got the trapezoid line and we've got the conoid tubercle as well. And now those are classified as two separate ligaments, but often they're talked about together. Okay, and we'll talk about that when we add the ligaments on. So we've got trapezoid and conoid ligaments, and then the attachment point on the clavicle is the conoid tubercle and the trapezoid line. Yeah, so there are two areas where they attach, but when you do a dissection of that area, they both look the same. Okay, so they both look as if they're the same thing, and you have to dissect down to get that separation. Okay, so they're often grouped together basically. And then the subclavian groove is going to be underneath here. Let's just play that through. Oh, that was it. So yeah, trapezoid, conoid, subclavian. So those are the key points on the undersurface of your clavicle. Okay, so as it spins around, we're looking underneath. So you got these arrows are pointing to nothing there. That's no good. So probably best to reference this picture. So conoid and then trapezoid up around here. Subclavian groove isn't too far off. That arrow is not too bad. Okay, so you get the idea. Yeah, so we're just trying to show in the real clavicle there and then related to the picture just there. Okay, cool. And then we're back to here. This is what I was meaning about the shape of the sternoclavicular joint. So the best way I can describe it is shaped like a Pringle crisp. Okay, depending on where you're living, Pringle chip. Okay, so we've got the so the sternoclavicular joint is an articulation, so a join between the sternum and the clavicle, which we know, we talked about that already, the manubrium and the first costal cartilage. So the manubrium is a specific section on the clavicle, on the sternum. So we're going to talk about that we've talked about that already when we've looked at the thorax and the ribs. Okay, so the manubrium is the top part of the sternum, and the shape of it is like a Pringle. And that's really important because it's like a double curved, which means it can slide back and forth and around. Yeah, so it can go that way and then that way, which is why we can do elevation, depression, retraction, protraction of the shoulder girdle because of the shape of that particular joint. And yeah, the best way, like I said, that I can describe it is like a Pringle crisp. It's reinforced by ligaments, and we're going to have a look at those in a second. There is a sternoclavicular ligament, so guess where that goes from? So your sternum onto the clavicle. And then a costoclavicular ligament. Costo or costal means rib. So we've got another ligament that goes from the rib to the clavicle as well, and again we'll have a look at that when we get to it. So we've got this reinforcement of ligaments around this joint just here as well. Cool. This is the joint that's not a joint. So the scapulothoracic joint is not a true synovial joint. It's basically made up of a load of muscles. And again, last week we were talking about it, and I posted on Instagram as well a little quiz, see if you could name them. There are 17 muscles that attach onto your scapula, and they all help with the, some of them help with the movement of the scapula, some of them help with the movement of this bone here, your humerus. So they, you've got two separate joints going on. You've got the scapulothoracic and the shoulder girdle, and you've got the glenohumeral joint, which is the ball and socket joint. Okay, so some of the muscles that attach onto the shoulder blade, they only affect the ball and socket. Some of them affect the shoulder girdle and the movement of the scapula. Okay, so again, when we get to the muscles, we'll talk about that, but just kind of teeing that up for you just there. So these are the movements that you can get from the shoulder girdle. So you're going to get elevation, so lifting the shoulder blade up, depression, bringing it back down again, retraction, bringing it backwards, and then protraction, bringing it forwards. All right, so you've got all these different movements there. Let's have a look at the shoulder girdle. I think we looked at this last time, but it's worth looking at it again, just to do a bit of a recap. So yeah, just a bit of a warning, if you're having breakfast, there's going to be some real muscles. Here we go. So there's the spine of the scapula, talked about this last week, and the acromion just on the end. There's your clavicle. Obviously we've been focusing on that on the beginning of this section. So sternoclavicular joint, acromioclavicular joint just there. There's your shoulder blade, scapula. And then that bit there is your glenoid. Let me just pause that back there. Just get that in the right place again. So we've got shoulder blade, scapula. And just pause that there. Cool. So we've got the H, which is the humerus. The G, which is the glenoid. And then the girdle is the attachment here. So where the sternoclavicular joint is there, the SC joint. We like to shorten names of things just to make it a bit more confusing. So sternoclavicular SC, acromioclavicular, which is that joint just there, that's AC. Then we've got the GH, which is the glenohumeral joint. So that's the glenoid, which is the socket. That's the humerus, which is the ball. And then they go together to form the GH. Okay, so we've got GH, AC, SC. All right, just in case you've heard those terms, you're like, what the heck are they talking about? So humerus into the glenoid makes the ball and socket, and then that's the movement. That's where the movement comes from for your shoulder girdle. Yeah, so everything's coming from that sternoclavicular joint just there. And as I said before, it's the only joint that attaches the arm to the rest of the body, the bony joint. Okay, so scapulothoracic isn't a true synovial joint. So SC onto the manubrium. There's your acromion, there's your clavicle, so that would be your AC joint just there. And then you can see the curve of the clavicle again, and you can see the projections as well. So the conoid tubercle just there. Just move that out of the way. So that lifting up is elevation, and you can see it all coming from this SC joint just there, look. So protraction, retraction. I'm just going to rewind that a sec. Just have a look at that again. So elevation, have a look at this joint. It's all coming from there. Depression, protraction, and retraction. Yeah, so we're getting those movements because of that Pringle shape. Yeah, because it's able to glide forward and back and side to side. It can do all of those movements, and obviously varying degrees of those movements. So you can elevate and protract, elevate and retract. Yeah, in every single kind of increment of those movements, you can do the others as well. All right, so again, really important for if you've got a shoulder problem, a GH problem, to also look at the sternoclavicular joint, because if this is restricted, then the other joint's going to have to work harder, and the muscle is going to have to work harder to bring about normal movements. So if you struggle with protraction, for example, and you can't go forward because it's sore or restricted or whatever it is, then you're going to have to try and reach a bit further with the glenohumeral joint, and that can put those structures under some stress. And depending on what you do, if it's a slow, insidious thing, then you may just adapt to it and it just becomes the way you move. But if you require that movement for athletic performance or your job and it's highly repetitive, then that can create a problem, and you can get tendinopathies, especially in the rotator cuff. So yeah, I'd definitely have a look at the SC joint for shoulder problems. Cool, so that's that. And then we've got this movement here as well called scaption. You may not have heard of this before. It's around about 30 degrees. So if you imagine there's 0, so a line through his shoulder there and his head is 0 there. So 30 degrees forward of the frontal plane, which is the plane that goes through the body in that direction. So 30 degrees forward there, that is the angle at which your shoulder blade sits on your rib cage, roughly. Obviously, everybody's going to be slightly different, but your shoulder blade does not sit at 0. Yeah, so the socket doesn't face that way. It faces slightly forward, and that's really important in rehab, because if you want to rehabilitate those shoulder muscles, obviously, if everything's working okay, then 0 degrees is fine to exercise in. But if you want a kind of neutral position of the shoulder, then scaption is a good place to be. Okay, and it may be a position where, say you're doing a shoulder press and you're getting some pinching in the shoulders, in that extreme 0 degrees position, like a kind of military press position, then just slightly bringing the elbows forward may alleviate those symptoms, because you're not stressing that glenohumeral joint. So if you're at a 0 angle, then you're stretching all of the anterior musculature and the anterior part of the shoulder capsule as you're trying to press. So sometimes it's a good idea to just bring the elbow in a little bit and then press from there, especially if things are sore. You just adapt to that position, and then as they get better, you can start going back if you need to press in that position. Yeah, so it's not a bad position to be in. It's just understanding the mechanics of the shoulder. So yeah, that's scaption. Again, if you've not heard of that before, and I think it's when I first kind of start to learn anatomy, I was kind of envisaged that the shoulder blade sat like 90 degrees, or the socket was 90 degrees, but it's not. It's slightly forward, so an angle of around about 30. So just to make you aware of that. And then we'll have a look at, so that was the shoulder girdle. Now we're going to have a look at the GH. Okay, so do you remember on that video we had the glenoid and the humerus, and then they joined together to become the GH. That's the ball and socket of the shoulders. So let's have a look at that. We've got loads of different bony landmarks over these areas, and they, again, the bony landmarks are formed from muscle attachments. So where muscles attach onto the bone, and then as you use those muscles during development, and as you get into adult life, they can change as well. They pull on the bone to create these lumps. And two of the major lumps that we've got on the humeral bone, so on the humerus at the top, is this one here, the lesser tubercle. Okay, so that bit just there. And then this one here, the greater tubercle, just there. And you'll notice there's a bit of shadowing in the middle here. And that bit there is called the bicipital groove. And that is where the long head of your biceps goes through. Okay, so it'll go through the valley between the two hills. So you've got a smaller hill, lesser, bigger hill, greater, and then the valley in between. Let's have a look what Becky says. Scaption, hence why stabilising the scaps during GH exercises can aggravate some GH symptoms. Yep, definitely. Yeah, so it's worth just playing around with the position of it. The way that I kind of describe it with patients, especially if they're in a lot of pain and they're struggling to do overhead movements, I'll try and take the muscle activation out by using a broomstick or something like that. So you hold with the unaffected arm, and then the affected arm is on the top, and then you push the arm up like that with a broom handle or something like that, just to give it a bit of support. And people will try to do like a perfect movement that they do on a gym machine, but you don't have to do that. That's not the way the shoulder works. So you can meander around the areas that are painful. So if you go up in that direction, you're like, oh, that's a bit sore. Okay, let's retract a bit, and then go up. Oh, that feels okay. Let's go up there. Oh, that's getting sore now. Okay, bring it forward. Can you go up there? And we just work a way around to get that shoulder movement back. And then eventually you don't have to worry, and you can just do it. But whilst it's painful, that's a nice way to get the arm up into full flexion. Just a little tip there for rehab stuff. So yeah, we've got crest of the greater tubercle, the deltoid tuberosity. So all of these, remember these when we get to our muscles, because, well, that's an obvious one. Deltoid tuberosity, guess what attaches onto there? Your deltoid muscles. And so there's a raised lump area here where the deltoid attaches, and it's a lot lower than you think. It's kind of like midway down the humerus, so the delts attach quite low. Yeah, so these ones are really key. Lesser, greater tubercle, the bicipital groove, they're all important. But this is the humerus. There's the glenoid. You can see that in kind of faded at the back there. So you've got your glenohumeral joint. Just another view. So this is a posterior view. There's your greater tubercle at the back. And one of the reasons why it is bigger, excuse me, is you've got more muscles attaching into it. You've got a lot of what we call the rotator cuff muscles attaching into the greater tubercle at various points along the whole kind of raised area. So we'll examine that as we get into the muscles. Shaft of the humerus, and then the deltoid tuberosity again from the back. Okay, so you can just make out those. And then the glenohumeral joint, this is a really nice image, because remember I was talking about joints having synovial capsules and synovial fluid, and the scapulothoracic joint wasn't a real joint because it didn't have those. Well, this is a nice image of those joint spaces. Okay, so there's your clavicle, there's the acromion, and then see the gap in between is the joint, which is like a plane joint, so it's fairly straight. And there's synovial lining, synovial fluid, and a capsule around it. Yeah. If you injure your shoulder, so you fall on it, bang it, irritate it, repetitive motion, that joint space can become inflamed, and it will swell and it will look like a lump. Okay. And if you have a scan of it, you can clearly see the fluid and the kind of irritation of that joint. And then that will affect your shoulder movements, because that joint also needs to move for you to be able to move your glenohumeral joint. So SC and AC have a big impact on glenohumeral joint movements. I had a guy who came off a bike and kind of landed on his shoulder, huge lump, yeah, and was worried that it had dislocated, but when we scanned it, it was just inflamed, and the joint was solid, so he was quite lucky, but it can look massive. Okay, so the swelling can look really quite big. Then the next one is this one here. So there's the head of the humerus, just there. There's the glenoid, so that's the socket. Can you see the socket is tiny compared to the head? Yeah. So that means we've got really good mobility all the way around this shoulder. But the problem is that it lacks stability. So because of the size of the socket and the size of the head being so different, it's really good for us to be able to reach up for things and, you know, pull things, push things. But what we have in mobility, we then lack in stability of this particular joint. The hip joint is a ball and socket, but it's completely the other way around. And for obvious reasons, because it's weight bearing, it has to be very stable, yeah, but it's not as mobile. And it's because of the shape. Yeah, so the shape helps with the function. Okay, but can you see this around here? Yeah, so there's this fluid lined capsule all the way around there, and that's the shoulder capsule, and there's a little bit of excess capsule down here, and that makes sense because if with the arm down by the side the capsule fitted the head of the humerus perfectly, you wouldn't be able to lift your arm because there's no slack in the capsule for you to be able to move it. So we've got this area where there's additional capsule so that it can elongate as you bring the arm up, and then it will come back down again as you bring it down, and it has to have that mobility. And the synovial fluid production within that capsule is stimulated by movement. So if you don't move it, you don't get the fluid production. The other thing that you might notice on here, so that this is a muscle and then there's a tendon just there, and we'll talk about what one it is when we get to that stage. And then this here, that's not a joint, although it looks very similar to this, but that is a bursa. And a bursa is a fluid-filled piece of connective tissue. Bursa means purse, yeah, and it kind of is a bit like a closed purse. It's got fluid in it, so that if it wasn't there, then that muscle and that bone would rub against that tendon, yeah, and it would wear the tendons out. So we've got these bursas in the joints to help reduce the friction in between those spaces. And in the shoulder, there's quite a few of them, and we'll have a look at that in a second, maybe today if we get to it today. So let me just show you this last bit on that one, and then we'll get onto the ligaments. Okay, so this is what we've just seen. So we've got the head of the humerus, so the ball part of the ball and socket. And then there's the lesser tubercle, there's the greater, and you can see that groove there, see the shadowing there. So the long head of the biceps goes in that bicipital groove. And there's a ligament that goes across. Yeah, so this terminology is from the Trail Guide to the Body book, and I mentioned that last week. We use a lot of that on this on these sessions. So two hills and a valley. So we've got the lesser tubercle as the smaller hill, greater tubercle as the bigger hill, and then the valley in between. Okay, and that's how it's described in that Trail Guide book. So yeah, you can see how big that greater tubercle is. It's quite spread around the joint, so the deltoid attaches down there, and again, like I say, it's quite far down. Let me just want to pause that right at the beginning there. Okay, cool. So these are some of the things. Now we're starting to add some connective tissue onto the bones. Yeah, so we're starting to have a look at the ligamentous tissue, connective tissue, see if we can work out what's what. So that's the collarbone. There's the acromion just there. This is the head of the humerus. That there is the long head of the biceps. It's a pretty good indication. It's got a massive arrow pointing towards it. And then this is the shoulder capsule. over it. So you can see the long head of the biceps kind of going into the capsule space. But the capsule surrounds the whole joint and then kind of envelops everything. Okay. And yeah, this area, this long head of biceps will pierce that capsule and then head towards the glenoid. And we saw where it attaches last week. So there's your coracoid, there's the acromion. You can start to see some of the ligaments as well. There's the long head of triceps attachment, and then this is the capsule. Can you see it's all squished up at the bottom? Yeah, it's like I was saying, you've got folds of capsule at the bottom because obviously your arm is normally down by your side, but then as you reach up, it will stretch and then allow that movement to occur, and the capsule will move with it. But that's the capsule. It's pretty tough stuff. Yeah, more capsule bunched up there, so you can see the movement of it. As the shoulder joint moves, the capsule allows that movement. There's the tendon for infraspinatus attaching onto the glenoid, onto the greater tubercle, sorry. So yeah, capsule just there. And you can see that kind of bunching up and then stretching depending on which direction it's moving in. And then infraspinatus tendon on the greater tubercle. Cool. Perfect. Right, let's have a look at these then. So now we're going to start to get into that ligamentous connective tissue a little bit more. We saw the glenoid labrum just then, and or bits of it anyway. And so you've got the glenoid, you've got the head of the humerus, and then we've got this labrum, which is another tough piece of connective tissue that deepens the socket. Okay, and the biceps tendon will come through this groove, come over the top of your head of the humerus, and then attach into the top part of the glenoid labrum. And then your long head of triceps comes up here and attaches onto the bottom part of that glenoid labrum just there. And we'll be able to see that in a second. So we'll have a look at that. In fact, let's do that now. Before we move on to the next bit, we should be able to see it on this one. Let me just get that video up. I don't know whether that's going to do the right one. Yeah, we'll see it here. There we go. Okay, so I'm just going to show this part of it, just so you can see the bit we've just been talking about. So there's the glenoid just there, and can you see these bits coming off here, and then a bit coming off there? So those are the ends of your bicep tendon at the top, and then long head, and then long head of triceps at the bottom just there. So there's your clavicle, there's your acromion. That's the socket of the ball and socket, so the glenoid, yeah, and the glenoid labrum is the connective tissue that goes around it to thicken it so that the ball is a bit more supported, but it's not a bony support, it's a connective tissue support, so it's a bit more pliable, so we've got a more range of motion. Just going to see if it zooms into that area. So if it starts going on to the other stuff, then yeah, here we go. So there's your glenoid labrum. So that's the picture that we've just seen on the PowerPoints just there. And you can see where the tendons attach. Yeah, so that's the long head of triceps attaching in there, long head of biceps attaching to the top there. Okay, so if you, and we talked about this last week again, you can have something called a SLAP lesion, which is a superior labral injury. And SLAP means superior labral anterior to posterior. So if you have your arm, say you're in a rugby tackle and your arm gets wrenched back, then the bicep tendon will get pulled from an anterior to a posterior position, and it's the superior labrum that it attaches to. So it's a superior labral tear from anterior to posterior. Basically your arm's been hoiked backwards, and that's where you get that injury. So if you've heard of that before, that's what that is. Cool. Okay, I'll just pause that there. So that's that. Let's add some of the other bits on. So we've got different ligaments again. So we've got ligaments of the girdle, ligaments of the GH, glenohumeral joint. Okay, so very different things depending on where they're based. So ligaments of the girdle, AC joint, and we've just talked about this in a bit of detail. So end of the clavicle, end of the acromion, and there is a ligament that attaches the two together. This is the one that I was talking about, that synovial fluid in it, and that cyclist hit and it went up like a balloon. So it's a synovial plane joint, and if you have a look at plane joints in the books, that means that they're kind of like fairly straight edged. They can be orientated in different directions, have little bumps in and stuff, but there is basically, there should be a gap between them so they can move. Yeah, they need to be able to move. It's an articulation between the acromion process, which is the end of your scapula, and the lateral end of the clavicle. So that, oh, sorry, just lock that in place. Yeah, so the lateral end of the clavicle, and it's reinforced by 3 main ligaments. So we've got the acromioclavicular, which is that one there. Okay, so the AC ligament. We've got the conoid and the trapezoid. Okay, so these two collectively here. Now, these two, like I said, they're sometimes named together, and again we'll add that on in a second. But the key thing to look at here is, do you remember that guy with a sprung AC joint? Yeah, where the clavicle had pinged off, and you could see that there was a gap in between this joint here. Yeah. Basically, if you fall onto an outstretched hand, this humerus bone is going to hit into the acromion, and then that's going to cause that separation. Now, you can injure these ligaments as well, and this one as well. Okay, and depending on which ones you injure will give you a specific classification of AC joint injuries, and we'll talk about that in a second. So if you just do like minorly sprain one, so that there's a bit of inflammation but nothing's actually ruptured, then it will be one classification. If you've done the whole lot, then it will be a different classification. Okay, so we'll have a look at that in a second. Oh, right now, I knew it was coming up. Okay, so we've got the Rockwood classification of acromioclavicular injuries, and this is back in 2012. So we've got the grade 1 as a sprain of the AC ligaments. So this is what I was talking about. So it's just a sprain, it's not ruptured or anything like that. The AC and the CC ligaments, so the coracoclavicular ligaments, are intact, and that's your conoid and trapezoid. Because they attach from the coracoid onto the clavicle, they're called coracoclavicular ligaments collectively. Okay, but that's those two that we've been looking at. And then if we go all the way down to the end when it's really bad, so at grade 6, we've got an inferior displacement of the distal clavicle, so the end part of the clavicle, the lateral part, is displaced, either subacromial or subcoracoid. So it's basically completely gone. Okay, this is usually a severe trauma accompanied by other significant injuries. So and that's what this cyclist was really worried about, that he'd done that kind of thing to his arm, because he did take quite a whack, but luckily he was okay. I have seen people not with a 6 but with a 3. Okay, so a deformity present with clavicle appearing elevated. I've seen those before coming into the clinic, or the acromion depressed, whichever way you want to look at it. The clavicle is unstable in both vertical and the horizontal plane. So because it's not attached onto the acromion, the clavicle is kind of floating around and it's free. Yeah, so these are the classifications that we use. And that one is a complete disruption of both the AC and the CC ligaments, but without significant disruption of the deltotrapezial fascia. So the connective tissue around the shoulder hasn't really been affected, but those ligaments have. Okay, so let's have a look at those ligaments. So we've had a look at the glenoid. I'll just skip through that. Here we go. So there's your coracoid, there's your acromion, there's your glenoid that we were looking at before, clavicle just here. And then we'll have a look at those ligaments. So we've got acromioclavicular just at the top there, trapezoid and conoid. So collectively they're the coracoclavicular ligaments just in there, in that space there. And then that's the classification that we've just seen. So I'll just go back there and then pause that. So clavicle, acromion, and then that bump there, that's your AC joint. So that's your acromioclavicular ligament. And then these are your coracoclavicular ligaments just in here. Now, can you see that one there? Yeah, because it goes from the coracoid over onto the acromion. So can you guess what that's called? Okay, we've got coracoacromial ligament just there. Okay, and that forms kind of like a roof over where some of the other structures come through, like rotator cuff, one of the rotator cuff muscles in particular, to attach onto the shoulder. All right, so we'll have a look at that in a bit more detail there. But can you see there's like an archway that is created by the coracoid, the ligament, and then the acromion just there. Yeah, and that's all on the outside of the shoulder. Perfect. Cool. So that's your sprung AC. Yeah, so the clavicle's elevated that we saw previously. So you can see now why we get that problem and which ligaments might be affected. And if you want to do a bit of research around the way that they repair it, it's a really fascinating repair. I love all stuff like that. But yeah, if you have a look at the Rockwood classification and then how they would surgically repair those, then just for your kind of interest. So last thing then, and then we'll finish off for today. So we've got the trapezoid ligament here, the conoid ligament there. This is nice, easy one, rather than that dissection, because it all looks the same. There's your AC ligament, so acromioclavicular ligament just there. So the trapezoid and conoid ligaments are collectively called the coracoclavicular ligaments, or the CC ligaments, and that's what they're called in that Rockwood classification. Cool. Another Monday done. So we're back next Monday, back to usual, episode 197 next week. We're getting ever closer to 200 episodes of this, which is just crazy. We'll finish off the connective tissue, and then we'll start adding on the muscle layers of the shoulder as well. If this is your first kind of foray into the ligaments of the shoulder, it might be worth just having a watch over those sections again before next week's episode, just to do a bit of a recap. Cool. I will see you next week. If guys that are on the Learn Anatomy Online private Facebook group, if you've got any questions and you want to ask me anything about today's session or any of the previous sessions in that group, drop me a message and I will answer it this week or on the next live session next Monday. Take care. See ya.